So welcome to the sixth Personalized Surgery podcast. We're honored today to have Dr. Krishna Kiran from Medical Cover Hospital from Hyderabad. It's very exciting to have you, Dr. Krishna Kiran, for our podcast. In this podcast, we try to bring renowned surgeons who are doing revision surgeries and how they are using personalized surgery to improve clinical outcomes. Dr. Krishna Kiran has done his MD from AIMS in Delhi and has 25 years of experience and has done some very, very complex cases. It's really great to have you on our podcast, Dr. Krishna Kiran.
Thanks, Ketan.
Yeah. So when we look at revision hip, right, and type of cases you get in revision hip, like what are some of the reasons these patients, like these implants fail?
So the most common thing is it runs its life. In the past, the quality of the implant polyethylene was not as good as it is nowadays. So people would have run the life of the implant done. The implant would get loose because of aseptic loosening, or the plastic which was put in would wear out. And this wear could cause bone loss, and then the implant would subsequently become loose. That is the best case scenario where the hip has lasted its life 15, 20, 25 years. But also at the other end of the spectrum, we have cases like infections. We have cases where the hip has become unstable for some reason, some technically poorly done surgeries which fail early. And these patients have an early failure, and they can also have periprosthetic fractures where they break the bone or something like that. So you have early failures and late failures. Late failures are something which we are not really bothered about.
Right.
The early failures are the ones which we are really worried about. And this is where training of the surgeons and choosing of proper implants and doing the surgery properly will help us, navigate this problem.
So in early failures, do you see any particular trend that, it's the cup position was wrong, or, the type, maybe it was uncemented use for an osteoporotic patient? Are there any trends you see in these revisions?
The people have issue with the acetabular cup positioning and the inclination and version still because of the challenge of exposing the hip properly. So I think the number one thing which we see is that the cup is not being positioned properly. And sometimes with the use of uncemented implants, then they may oversize or undersize it, the stem side as well. So the stem, when you're hammering it, it can fracture the bone, or you're undersized it, so it becomes loose and sinks. But also in India, post-COVID, we have seen a huge explosion of infection as well, because something to do with immunity which has come down. The type of bugs are different. So although thankfully it is not that much, we still have septic failures.
Right.
And finally, we have instability, where if you don't put the cups in the correct position, the hip will dislocate, especially if the malposition is too much.
So in the, the cup, when at the first place, if the cup was not positioned correctly, if the alignment was, the inclination version was incorrect in some of those, primary cases where they fail, do you see a particular trend saying, it was too open or too close, or is it too anteverted, retroverted?
Yeah, that's right. So I think the cup would be more anteverted to start with, and maybe more vertical. So it would dislocate. Or sometimes the cup version may be too little, where it is retroverted, and then the hip would dislocate posteriorly or something like that.
Okay. Now, when you do your, say, primary or even in revisions, do you do like X-ray based planning? Like how common is it, and what do you think about like X-ray based as well as like a CT based preoperative planning?
So for most cases, an X-ray based planning should suffice. But if the case is a slightly complex case, which you have to identify on the X-ray, of course, we would not hesitate to do a CT based planning on them. But if there is access to a CT based planning for every case, that would be the best case scenario, because you would get details about the size of the socket very accurately, size of the stem which we are likely to put in, neck shaft angle, and you can look at the anteversion of the femur as well. So you have a reasonable idea as to what you're looking to plan.
Awesome. On the revision side, right, when you have like type 2A, 2B type deformity, like when do you choose saying, okay, this is a standard? Do you have that visibility beforehand in terms of saying, oh, this is a standard of the shelf, is I'm good, or I need to do some personalization for this particular case?
Again, if you look at the x-rays of the patients with failure, you will know based on the extent of the hip center migration, whether we are dealing with a major defect or a minor defect. So generally, if the migration proximally is less than 3 centimeters, you would be able to get away with a standard type of a reconstruction. The exception to this particular situation is an old acetabular fracture or something like that, which has been operated but failed for some reason. Here you will have a more complex interplay of column wall deficiencies which can coexist, where you may have to do a customized planning and customized implantation. But in cases which have got a proximal displacement of more than 3 centimeters, then these are cases definitely where we would plan for a CT based planning as a blanket, everyone. And then based on the CT findings, we will decide whether this patient will require any custom implant or we can just get away with a standard implant.
Understood. So share with us your early experiences of custom implants, like when you did your first, like maybe if you can share.
The first case was a patient who was 10 years on bed, and she was operated multiple times 10 years back, had a lot of infections, and then they just chose to do a girdle stone. She had a big column and wall deficiency of the acetabulum. So I heard from Dr. Vijay Bose at that time that he had started designing these columnar docking augments. So that was my first experience where I got a customized augment made, and I used that in that patient, and she went on to do well with that particular reconstruction. Subsequently, we have used at least 14 or 15 of these custom implants in some of the more complex, multiply operated patients, failed revisions. And my personal experience has been really, really good because it allows us a 3D orientation of how the bone is, what is the residual host bone contact, whether I need to use a flange triaxial locking cup or I need to use an augment with a cup in larger defects where I can delink the two, or I just need an augment or a cone or a cage, whatever. So I've been able to simplify my surgery significantly, and most of the times the augment tends to fit just like a glove onto the thing because it's a CT based plan. And the patients also have done pretty well for the complexity with which they presented.
So, when you did your first case and now, after so many, what has changed in terms of intraoperative, when you did your first case, like, are there learnings that if you can share, that would be great.
So we now actually play a more significant role in the designing itself. We tend to put the opposite hip as a sort of a template for the preparation of the augment or the cup. And this way we are not going too far posterior, or sometimes the engineer tends to go overboard with respect to filling of the defect, which is not always a good idea because you have to understand that inside the surgery, there is a lot of soft tissue, neurovascular structures which we have to take care of. So we should try and design something which is fittable in the individual patient, not something which is large, taking care of every single defect. So sometimes we would actually ignore a part of the defect and then see what actually works, try and restore the hip center, and then that has become much more fine-tuned now. And then we have introduced certain tweaks like a handle for the augment, which is similar to the cup handle, which is a commonly available cup handle. So you can put the handle on the augment and then fine-tune the positioning of the thing. So the surgery becomes much faster, and we have now realized also that we will not try and do any sort of implantation before the exposure is complete.
Right.
So we will make sure that the model is autoclaved and ready on the table, and exactly how the model is, if your exposure is not there, you will not be able to fit in your custom implant. So it's a challenge with the exposure, not with the printing or machining of the cup. And this is where you must show a little bit more patience to be able to remove all the fibrous tissue, get into your anterior, posterior, superior and inferior bony margins, which are the things which we are planned for. Once you reach that, I think it becomes a very significant cakewalk. So it's all about exposing the thing properly.
is the time for exposure significantly higher compared to say standard, or when you use say standard revision augments that are available?
The time actually is desirable. I would rephrase that particular question. Sometimes when you're using off-the-shelf augments, they don't really fit the defects which are there. If it's a smaller defect, say a 9 o'clock to a 1 o'clock defect, then it won't really matter. You would dream it and get out. But if you're dealing with a defect right from 9 o'clock to 3 o'clock position, then I would want in a suboptimal situation where the host bone is poor and has got less contact, I would need a custom augment which would sit exactly where the host bone is. So by creating a flange triaxial locking construct which has an augment inbuilt into the reconstruction, we have options of fixing the ilium, ischium and pubis together, and this actually simplifies the operation much more. So the exposure, I think even for a standard case, we should do the same exposure.
So worth the time you spend to
it actually makes you a better revision surgeon while using the standard off-the-shelf things also, because now you know how to optimize your exposure for revision as well, rather than being impatient and trying to get out fast.
And is the typical exposure bigger than your standard?
No, I don't think so. It depends on the defect. If the defect is large, sometimes we may have to modify our exposure, go a little bit front, do a Gibson approach, identify the inferior branch of the superior gluteal nerve, and then try and protect it while we are doing it, because this can get easily damaged when the defect goes more than 3 centimeters above the superior rim. So we just looked at a cadaver study which is published in the Journal of Arthroplasty, and we found that sometimes the distance is as low as 2.5 centimeters from the margin of the acetabular. So when we are dealing with high-grade defects in smaller patients, it's a good idea to expose this inferior branch. Because we don't expose it often and probably inadvertently damage it, the incidence of instability in revisions is higher than primary.
So that might bring in another, like making sure that those soft tissues are taken care of.
So you commit to a particular exposure, you commit to that particular thing, and revisions can be simple, but they can also take a lot of time. Here, like you rightly pointed out, it's about patient outcome, which is the key here. So if we spend 1 hour extra to give patient 5 years more, I think it's worth investing.
Nice. Dislocation rate or dislocation in these kind of situations, is that common, and what do you do to reduce that risk?
So the complex revisions, we routinely use a dual mobility cemented liner into the custom augments or the off-the-shelf things. And we tend to use highly porous cups. So we use the trabecular metal cup or the redapt cup from Smith Refio, and we have which is called latitude revision cup. These cups have porosity on both outer and inner surfaces, just like the customized ones which we are making. And they have option for inferior fixation. Although the inferior fixation option in a custom cup, I would say, is superior, because you have actually mapped the superior pubic ramus and ischium. So even in inexperienced hands, trying to put in these screws will not be that difficult.
Understood.
The key challenge, however, is the exposure is inadequate. So they try to fit in the FTL into a
smaller
suboptimal incision, and there now then the screws will go off or the position will go off. Another advantage of customization is the 40-20 which we are taking in is with respect to the pelvis. So we have a sort of a ready-made situation where there is added incentive to expose better, because now once we are able to seat the component properly, your inclination and version are not in error. And if you remember, we spoke about how in primary situations a malpositioned cup contributes to instability. So with these custom implants, if you actually position them well, it will not be related to the version. Now the instability will be related to the inadvertent nerve damage or inability to restore the soft tissue offset or something like that.
I see. So if you fit it properly, your plan gets
9 out of 10 times you will not have instability.
Then you don't have.
If you are having instability, it means that you have not fitted it well.
Understood. Okay. So there is also this trend of direct anterior approach and all, and you have been a proponent of that. Do you see that these kind of revisions can also be done with direct anterior?
Yeah, why not? The revisions can be done. There are surgeons who do all the revisions from direct anterior approach. It's just another approach. So I think there is too much of fuss on the approach. It's about how you get the surgery done well. If somebody is able to do it through a smaller incision without damaging anything, so be it. But if you think that you are not capable of doing that and you want to stick to a traditional approach, I don't think at the end of 2 or 3 months there will be much difference between this and that.
Right. So it doesn't really matter.
It doesn't matter.
Whatever
it's a good thing, attractive thing for a patient, right?
Right.
If you are discharged on the same day or the next day, are able to walk. But if you go home and if the surgery is poorly done and come back after a month for a revision, it's not worth it. So the approach is an add-on. It's a sort of it's a jewel in the crown. It's not the crown itself.
So in primary situations, this is more probably better, but in revision anyway, the focus.
So again, in the revision scenarios, like as I told you, if you're doing posterior and you do Gibson approach and identify the bundle, then the risk of nerve damage is lesser. But if you do the proponents of the direct anterior revision say that we are not, damaging the gluteal muscle or something like that. So the risk of instability is again lesser. So it makes some sense. But it's now no longer a minimally invasive option. It's an extensile approach where you are removing the tensor fascia from the ilium, and also on the femoral side you have to identify the first and second neurovascular bundles of the femoral nerve below the lesser trochanter. If you are choosing to do some sort of a transfemoral approach, and this is something new to learn. Right. So in a complex situation, it's not a good idea to learn an approach. Right.
Understood.
Yeah.
So, do you see any value of, say, navigation or robotics in these revision surgeries? Like, would you benefit from having some sort of positioning system that would allow you to do this?
I think the future will be with robotics and CAS, because we should remove the human ability out of the equation.
The
human ability is important, but people we know are of varying levels of skill, knowledge, and ability. So that should not compromise the patient. So if you have a robotic technology, the average surgeon also will be able to perform well, and eventually the patient will get benefited. The real challenge is whether to see this will become cost effective with the numbers which we have, and that's for the industry to figure out and the hospitals to figure out. But as a surgeon, I would not want any sort of an error into my surgery. So if in a complex revision surgery, we are so happy with the CT based planning, imagine what can happen with an intraoperative CT, where the screw trajectory, we can intraoperatively map the pubic ramus, ischium and ilium. And now it no longer depends upon the skill of the surgeon, it depends upon the technology.
The system kind of takes over and guides you in every step. So
absolutely.
It's only benefits.
Just like an aeroplane. Aeroplane in the past was through a system called as pilotage, if you are aware of it. So in the 1920s, 30s, when it was first developed, if it had to land in Paris, it had to see and identify the Eiffel Tower. In Delhi, it had to identify the Qutub Minar. Now with very poor visibility, zero visibility, also you have a global positioning system. And if the positioning system were of error, you would have had so many more plane crashes. So current arthroplasty, if there are 3 lakh arthroplasties being performed in the world and the failure rate is 1%, you're looking at 3,000 failures. Imagine 3,000 flights crashing in a day. So I think the focus must be towards error-free surgery, and any factor which is causing the error must be eliminated.
Nice. What message would you like to give to some of the younger, newer surgeons trying out this technology, and anything you would like to share?
The only message I'd like to give to the younger surgeons is each human being wants their own success, their own validation, their own growth. But I think just pause for a moment and take the attention from yourself to the patient, who is a fundamental aspect of the entire game here, because he has come here to you to get better, get healed, So we all have a greater purpose. I think we should get beyond petty issues of personal ego, pride, and trying to show what we are actually not capable of, and put yourself in the patient's shoe and see what is best for the patient. And once this switch happens from yourself being a great surgeon or a big person or somebody who is trying to show off, to the patient who is actually getting benefited from your expertise, then you become more humble and you become more open to learn, and then you are open to talking about the flaws and all. And in a culture where the flaws are all hidden under the carpet and no complication ever happens, I think we must have a systematic data documentation program, and we will realize that a lot of good looking x-rays on the day one actually have become a failure at the end of a year or two. So properly done follow-up, as someone said, will ruin an excellent looking initial X-ray. So I would like to inculcate the scientific temper and also empathy and compassion towards who we are taking care of. Don't lose sight of the fundamental goal of the entire profession, that is taking care of patients in a safe, reliable and effective manner. And if that entails more training, so be it. If it entails asking a friend, so be it. If it entails referring the patient to someone else who is able to do a better job, so be it. And if this becomes the fundamental for all the doctors, then people will train better. They will be able to openly look at their own complications to improve, and eventually the patient care will improve.
Amazing. Thank you so much. It's a real pleasure to have you for our podcast. We really appreciate your time.
Thanks, Ketan, for having me. Thank you.